Hey everyone. Okay, so this chapter is my favorite chapter. And why that is? Well, it's mental health. And because I'm a therapist, this is my favorite chapter because we talk about mental health disorders. So, dive in. This will be the longest lecture. I could probably go on and on and on with this one, but I'm going to try to condense as much as I can. I have added in so many links in addition to what is in your text, but I believe that you will find this to be a very interesting chapter. And if you are interested in mental health and pursuing a degree as a clinician, whether that's a therapist, counselor, psychologist, psychiatrist, whatever. This is a great chapter and it's a great semester long course. So, some call it abnormal psychology for, you know, the purposes of this text. They changed the name to variations in mental health. It used to be called psychological disorders, but I believe they wanted to kind of clean it up. So, anyways, what I did further was just to give you kind of a taste of mental health. I put in all of the diagnoses for what's in the DSM. So there are a few updates, things that they're adding, but for the most part, you're getting a lot extra in this chapter. All right, so we start off, of course, with the study halls and crash courses. We have 3 new study halls: diagnosing and defining disorders, TikTok diagnoses versus psychologist diagnoses. This is a really good one to watch. Substance use disorders, and then, of course, these are all the OG crash courses. They are still all relatable. But you can see there's a ton, and crash course really breaks them down. They're just a little bit dated, whereas the study hall, of course, are, like I've said in previous chapters, they're more current. All right, so as you can see in this preview, there's a lot of things to go over. So when do behaviors become symptoms? Neurodevelopmental conditions, anxiety and anxiety related conditions, trauma and stress related conditions involving emotion and mood, eating disorders, schizophrenia spectrum, personality disorders, suicide, and combating stigma. All right, so when do behaviors become symptoms? All right, so according to the text, you've got 3 criteria for evaluating behavior. So it has to be atypical, so behavior deviates from the norms of a culture. Maladaptive, behavior disrupts the person's ability to lead a satisfying life. It interferes with their ability to function effectively in the world. The behavior is personally distressful when the person engaging in the behavior finds it troubling. So, as a clinician, when you're diagnosing or you're working with someone, if it is going to be kind of um, not labeled but diagnosed as a disorder, it has to meet the 3 Ds, which are deviant, dysfunctional, and distressful. And it has to be more days than not. So if you're simply having a rough time in life and it doesn't meet the criteria, then it's not going to be a diagnosable mental health disorder. Um, if you decide to further your academia, they include a 4th D, which is dangerous, but that is not mentioned in this text. All right, so when we look at culture and the meaning of normal, culture establishes the norms by which people evaluate their own and others' behavior. Definitions of normal change as society changes. Norms can be limiting, oppressive, and prejudicial. So basically, what our idea of normal is, right, in our culture might be significantly different than another culture. So normal is really, it is defined by what is the everyday to day in someone's culture. Everything does change. All right, so cultures vary in how they evaluate behavior. making it very difficult to compare psychological diagnoses across different cultures. So, again, what may be considered a disorder in our culture would not be, that would not be out of the norm in a different culture. So it does vary. Many diagnostic categories reflect Western notions of what is typical. All right, so going back to the theoretical approaches, because I've talked about this before, we've got the biological approach, which uses the medical model. Mental health conditions have biological origins according to this approach. So we're just looking at biology if we're just looking at this approach. If we're looking at the psychological approach, this emphasizes experiences, thoughts, emotions, and personality. So it's looking more about what's within the person, not the biology of the person. Then we have the socioculture approach that emphasizes social context like gender, ethnicity, socioeconomic status, family relationships, and culture. And that's really important. So, as a clinician, what we do is we use a biopsychosocial model, which brings together these three things: the biological, the psychological, and sociocultural. Because you're not just your genetics, you're not just your experiences, and you're not just your like situation, environment, things like that. It takes all three to kind of blend together. So that is the reason we have this biopsychosocial model, and that's the interaction of biological, psychological, and sociocultural factors. All right, so now looking at the DSM. So obviously the DSM is how we diagnose mental health disorders. No matter how much I understand depression, anxiety in my practice, I still have to make sure that if I'm going to diagnose a client, that they meet all of the criteria. And some mental health conditions have a certain amount of criteria. They're not all the same. Some you have to meet 3, some you have to meet 5, some you have to meet 7. It just depends. So again, we have to make sure it's deviant, distressful, and dysfunctional, and it's more days than not. All right, so advantages of using the DSM. This provides a common basis for communication, helps clinician make predictions. Naming the disorder can provide comfort. So it's not labeling the person. So if someone suffers with alcohol use disorder, AUD, typically as clinicians, we're not going to say he's an alcoholic, she's an alcoholic, she is schizophrenic, she is bulimic, all the ick, right? It sounds like the ick in there. This is what I learned in grad school. We're not labeling the person, right? Because they are not their diagnosis. This is something they live with, and it's something within them, but it's not what defines them as a person. So it's really important that we're not, naming them as the disorder. But it does bring comfort because sometimes people, especially with autism, they find, oh, I'm quirky, I've got these kind of characteristics. And now knowing that is what I'm living with, it makes sense. And now I don't feel weird. So that's kind of the pros of having this DSM model. The disadvantages, of course, there's going to be disadvantages. Stigma, so shame, negative reputation, if we allow that to kind of influence what is going on. Treat psychological disorders as essentially medical illnesses, focuses on weaknesses and ignores strengths. Well, when I say that's okay, it's because there is kind of a yin to the yang. So the DSM classifies the disorder, but guess what helps with it? The therapy part. So it's not supposed to really kind of look at the strengths. That's what we hope that therapy will kind of uncover and help with. All right, and it relies too much on social norms and subjective judgment. So it's important that when you are working with a client, you're asking a lot of questions, you're ruling out things, you're finding things for support, because just looking at the DSM is not enough. And it also promotes overdiagnosis. Too many categories of disorders broad standards for diagnosis, which is the reason that some disorders, whether it's ADHD, which is a neurodevelopmental disorder, gets overdiagnosed. There are some things that are just overdiagnosed that are not necessary. All right, so now let's talk about some terms that go along with these mental health conditions. So, comorbidity is the simultaneous presence of two or more mental health conditions in one person. So, again, has to be at least two, it can be multiple. That means that usually when someone has depression, they also have anxiety. Doesn't mean they always do, but comorbidity just means that there are a presence of two or more conditions in one person at the same time. Etiology, if you ever hear that term, etiology means the causes of mental health conditions. So when we look at etiology, we're looking at the cause. Risk factors are the characteristics, experiences, or exposures that increase the likelihood that a person will develop a mental health condition. And then psychotherapy is a non-medical process that helps individuals with mental health conditions recognize and overcome their problems. So psychotherapy is more deeply ingrained, right? So if you're going for psychotherapy, it's usually because you're going for a mental health condition. They're interchangeable with the word therapy. A lot of people say, I'm going to therapy today. And that, therapy and counseling are interchangeable terms. If you want to remember the difference between the two, psychotherapy or therapy is more deeply ingrained, right? Psychological issues, whereas counseling is, let's say something happens in life. You go through a breakup or you lose a job or you're stressed out and you just need to talk through and work through problems. Maybe you don't need any medication, so you don't need to see a psychiatrist. You're just trying to work through this bump in the road. So that's kind of the difference between psychotherapy and counseling. All right, so now here's where I add in a lot of my own stuff. And this is the first set of disorders in the DSM. This is not in your text. You'll find some of these things, but I love to give examples. So all of these are links that you can click on. So in neurodevelopmental disorders, you've got those. So intellectual disabilities, communication disorders, autism spectrum disorder falls under neurodevelopmental, not necessarily psychological. ADHD, specific learning disorder, and then motor disorders like Tourette's and tic. Now, what I've done is I like to give real world examples of people to kind of lower that stigma, to show you whether they're interviews or just really cool videos that I find. So in this set, you've got Billie Eilish. This is an older one, and she talks about her Tourette's disorder on the Ellen DeGeneres show. This is an 11-year-old girl with Tourette's and her talking about it. Tic disorders associated with TikTok. More extreme cases, this is a very interesting one. It's a group of people that meet each other and they all have tic disorders. And when they meet each other, their tics are feeding into each other. So everybody is ticking at the same time. Very interesting. And then Deuce Bigalow is a really funny movie from back in like the 80s. And there is when we think of tic disorder, we think of the most extreme case, but it's actually very rare for this particular scene in this movie that you'll see. It's less common, but it's still a thing. All right, the next set, I'm not going to read these all, but this falls under the schizophrenia and related disorders. So a lot of people don't know that schizophrenia is not just that. So schizophrenia is the umbrella term, right? There is schizophrenia right here, but under this category, there's all of these other forms of schizophrenia disorders. These are your bipolar and related disorders. So bipolar, this is bipolar 1, bipolar 2. Bipolar 1 is more of the manic, and then bipolar 2 is more of the depressive, so hypomania in here. But there is depression and mania. And it used to be called manic depression, but the stigma, again, sounds very stigmatic. So they just renamed it bipolar because bi means two polars, up and down, mania and depression. And then cyclothmic disorder. All right, then your depressive disorders. Here are all your depressive disorders. Disruptive mood dysregulation disorder. This is for children and adolescents, which can then move up to either major depressive or persistent depressive disorder, used to be called dysthymia. Then there is premenstrual dysphoric disorder for women, and then other depressive disorders. You're going to find through many of these different chapters. Now I'm going in order of my DSM that are categorized of the disorders. You're going to find a lot of times at the very end, there's going to be other whatever disorder it is. And that's usually due to substance or some medical condition. All right, here are all of your anxiety disorders. So you've got separation anxiety, which is children, selective mutism, specific phobia, social anxiety disorder, panic disorder, and then it keeps going. Agoraphobia, it gets its own classification under anxiety disorders because it's the largest phobic diagnosable phobia disorder. So it gets its own. And then phobia, there are so many different phobias. And then, of course, generalized anxiety disorder, which is a hugely diagnosed disorder. All right. OCD used to years ago fall under the anxiety disorders, but because they're so much more prevalent now, they get their own chapter. So we've got OCD and they fall under this obsession and compulsion. So we've got OCD, the classic OCD, body dysmorphic disorder, hoarding disorder, trichotillomania, which is hair pulling, excoriation, skin picking, and then OCD, again, related due to substance or medical. Here are all of your trauma and stressor disorders. You know, the largest one is PTSD. The most diagnosable, so fun fact for extra credit if you need it, the most diagnosable disorder is adjustment disorder. So if you want extra credit, email me and let me know that. So adjustment disorder is so if a clinician really isn't sure what your disorder is yet, now again, we can get into the logistics of it. If you accept insurance, if you are a clinician, I don't accept insurance, but if you do, you have to diagnose day one. And here's kind of like the catch-22. You have to diagnose, but you can't overdiagnose because you can also get in trouble. And years ago, and probably still happens now, therapists were getting in trouble for overdiagnosing adjustment disorder because they were like, I don't know exactly what it is, but you have to diagnose something. And adjustment means I'm adjusting to something, right? I'm adjusting to whatever life change. It has to be at least 3 months, right? It only has a 3 month like shelf life, if you will. After 3 months, you have to diagnose something different. It can no longer be an adjustment disorder. So it only has that 3 months. So again, fun fact, adjustment disorder, let me know. Here's your dissociative disorders. Main one is DID, used to be called multiple personality disorder. Again, we don't call it that anymore. It's not diagnosed that anymore. It hasn't been for years. DID is very, again, a lot of people come to me and they're like, is it like Split? And I'm like, okay, Split. No. Yes, no. Split is dramatized, demonized, and it's not reality based. Are there elements of truth in there? Yes. But please don't look at that movie and determine that that is what DID represents. Also, I've had many people have been like, oh, I think I have DID. Of course, they diagnose themselves on TikTok. DID is a very, very, very rare disorder. It is a disorder, but it's extremely rare. Most clinicians will not ever see a case of DID. I do put some interesting and factual videos in here for you to look at, but DID has to be diagnosed very early in life. So if you're 11 or 12 and something happened, you cannot be diagnosed with DID. That would be a case of maybe PTSD. But DID is you split, right, into two separate like personalities. You have to have two or more distinct personalities to be diagnosed with DID. And when you are, in a different, personality, you can talk Spanish or French or have a different job. It is such an interesting disorder. But again, when some clients have come to me or some former students and they're like, I have DID. I'm like, I don't think so, but let's talk about it. And I'll refer because, that's a very specialized psychoanalytic field that takes a lot of time working with a client. Sometimes it's 3, 4 times a week in therapy. And there's bouts of not remembering. So amnesia, different things like that. But again, great, a very interesting disorder to discuss. But unfortunately, it is over dramatized in the media and just not accurate. All right, here are your somatic symptom and related disorders. A lot of really good links that describe these disorders. This one right here, if you remember Gypsy Rose, she had what was called it was Munchausen syndrome by proxy. So her mother had it and inflicted these, unrealistic medical conditions on Gypsy. And it used to be called Munchausen syndrome. Now, when that was diagnosable then, so if you were diagnosed with that, you're kind of grandfathered into that diagnosis. Today, they've renamed it and it's called factitious disorder. So it's factitious disorder or factitious disorder by proxy. When it's by proxy, like with Gypsy Rose, that's when it is like the mother was inducing these behaviors on the daughter. When it's just the disorder itself, it's doing it from within. So these are a bunch of really interesting videos. And I have clients that have health anxiety, right? So this is a good explanation of that as well. All right, here are your feeding and eating disorders. So you've got pica, rumination, avoidant, restrictive, food intake disorder. So this disorder is you're a very, very picky eater to the extreme. It's not about weight loss, weight gain, anything. It's just you're very picky. And they call this ARFID. So if you've ever heard of the term ARFID, that's why it's ARFID. Pica is eating non-nutritive stuff like chalk. You'll see that in Strange Addictions, I think it is. So it's like dirt, cotton, eating, all that kind of stuff. And then, of course, you have anorexia, bulimia, binge eating disorder, and then other. Your elimination disorders, enuresis, that's urine, and encopresis is feces. Here are all of the sleep-wake disorders. There are a ton of them to explore. Gender dysphoria finally made it into the DSM after the third one. So we've got gender dysphoria in general, then we have it in children, and then in adolescents and adults. Here are your disruptive impulse control and conduct disorders. You got oppositional defiant disorder, ODD, intermittent explosive disorder, conduct disorder, antisocial personality disorder, which this is the disorder that are your sociopaths and psychopaths. So psychopaths meaning your serial killers. Now, in order to be diagnosed with antisocial personality disorder, you first have to be diagnosed with conduct disorder earlier in life. And then we have pyromania and kleptomania. So pyromania is fire, kleptomania is stealing. With these two disorders, it's all about the impulse. So it's not setting fire because you're trying to get insurance money or anything like that. It's just doing it for the sake of the rush that you get. And again, it has to meet criteria to be diagnosed. Here are all of your substance related and addictive disorders. So many, I'm not going to read them, but they are there. Here are your neurocognitive disorders. It starts off with delirium. There are so many of them. And as you can see, due to this, due to that, so there's many different types of neurocognitive disorders. Here are your personality disorders. One a lot of people like to talk about. Your cluster A are your paranoid, schizoid, schizotypal personality disorder. These are also found under the schizophrenia umbrella. So some of the disorders are found in other chapters as well. Cluster B are the hardest to treat. These are, if you notice, antisocial personality disorder. Don't let the name fool you. It does not mean, I've had people say I have an antisocial personality disorder because I don't talk to people. Actually, it can be quite the opposite. Your psychopaths and sociopaths can be very clever and charming. Some have families. But these are the hardest to treat because these are more of the disorders where they don't believe they're the problem, everyone else is the problem. So as you can see, antisocial, histrionic. If you think of the character Regina George from Mean Girls, if she was going to be diagnosed with a disorder, it would be histrionic. At least that would be one of them. Borderline personality disorder, and then narcissistic personality disorder. I have some great videos for narcissistic. I highly suggest you checking them out. Dr. Ramani is the leading doctor in narcissistic, understanding it. And she believes that it shouldn't even be a personality, or it shouldn't even be a diagnosable disorder, because if you think about it, narcissists are not going to counseling. They are not trying to get a diagnosis. Usually a narcissist will go to counseling because their loved one or someone has said, you're a narcissist and you need help. So what they try to do is they try to go to a clinician. They try, and I've had it happen to me. They try to butter you up. They try to, get you to believe that it's their partner that's crazy and something is wrong with them. And then they go home to their partner and they're like, yeah, even the therapist agrees with me. So it's insanity. So should it be even on in the DSM? No. Should we know about it? So we know when we're dealing with a narcissist? Absolutely. But again, very interesting. And then we have your cluster C, avoidant personality disorder. So either we avoid, or dependent personality disorder, opposite, and then obsessive compulsive personality disorder. There is a distinction between OCD and then OCPD. Again, so much to go through. And then others in the DSM, paraphilic disorders, those are your sexual kind of like your pedophiles, the peeping toms, exhibitionist disorder, like the flasher, voyeuristic, which is the peeping tom, those type. And then you've got your medication-induced movement disorders, and then sexual dysfunction. So I don't go over those, but you can look at that yourself. You can go on psychiatry.org and look at all the different disorders. There's a lot more explanation, so very interesting. Okay, this is where we actually jump into the chapter, and I also put lots of links in here. So ASD is the first one under neurodevelopmental. This is the one that they cover in the text. So ASD is persistent deficits in communication and social interaction. Some things that we have to note that we notice in ASD is restrictive, repetitive behaviors, interests, and activities. So they're lifelong, symptoms often evident in infancy, preoccupation with particular objects or activities. Diagnosed incidence has increased actually quite a bit. No longer use the term Asperger's syndrome. So if you were diagnosed with Asperger's, you're kind of grandfathered into that, but there's no new diagnoses of Asperger's. It's now just autism is on a spectrum. So it's diagnosed on that. Level of impairment is extremely variable. This is why there are various spectrums. Advocates assert that ASD should be understood as a type of valuable neurodiversity. So again, it falls under neurodivergency. Some people are neurodivergent but do not have ASD. Again, you have to meet the criteria. And so many people I have come across in my practice have said to me, well, I'm autistic. I have autism. And I ask some questions and I'm like, okay, I'm going to refer you to a neurodevelopmental psychologist so you could get a proper either diagnosis or they can rule it out, because often you have these tendencies, right? You may have these certain quirks, but it doesn't mean you have autism. It just, we can have these little, things, but it doesn't mean we have a disorder. They have to be in all disorders, deviant, distressful, dysfunctional, and they have to have certain criteria met. So if something needs 6 criteria, but you meet 5 of them, you're not going to get the diagnosis. And this is the reason we have that. So etiology, what does that mean? Those are causes. So cognitive, lack of understanding of theory of mind. Social motivation approach is lower social motivation attention. Sensory processing approach, sensory focus on fine details rather than the big picture. So often people with autism, it's very hard for them. They lack theory of mind. So they lack that thinking outside of the box. Sometimes, many times, they often lack empathy, not because they don't feel for people, but sometimes if someone is like crying or in pain, sometimes someone with autism will be like, why are you crying? What's wrong? And then they might say what the reason is, and they're like, I don't understand. It's just having kind of that block. So it's not because they don't care, it's kind of that inability to have that because they lack theory of mind. Many are highly sensitive to sounds and touch. Often they don't like something very loud. They'll cover their ears, or they'll wear headphones. Difficulty organizing sensory experiences. Some genetic and neurological basis. Again, it can be through hereditary. It's passed down through the male gene. And then it can be something neurological. So, you know, you're obviously born that way with lacking the mom passed down something. But what I'm saying is, I shouldn't say it like that, because it's a male passed down gene, but it could be something neurological during, pregnancy, but it's a male dominant, like passed on genetic basis. All right, so etiological diversity as well, often treated with applied behavior analysis, so ABA. There's no medication specifically for autism. Usually what's given is anxiety meds. So when, someone with autism might be going through something, the anxiety medication can kind of lower that kind of amped up feeling. And then depression medication. Now in today's it's very interesting that older, depressive medications were just used to treat that. And now we're finding that certain medications can treat 3 or 4 different types of diagnoses. All right, so if you click on this link, this is this is good from the SciShow. So from the guys from Crash Course, this is a good discussion on autism spectrum disorder. I'm going to skip over that. Okay, let me get back to boom. Okay. All right, now jumping into ADHD, we've got biologically based, appears in childhood. Inattention, hyperactivity, and impulsivity are the ingredients to be diagnosed with ADHD. Question, is it overdiagnosed? Yes, it is. That's kind of the question posed in the text. Traditionally considered a childhood disorder, 70% continue to experience symptoms later in life. Not necessarily as much, but many children can kind of get through ADHD, and then the presentation is lessened into adulthood. It is associated with lower academic performance and poorer peer relations, especially if there's no medication compliance. So, again, it depends on, especially if you're a child, if your parent wants to put you on medication, but some of the fears are stimulants, but they do have non-stimulants as well. All right, so some risk factors: premature birth, prenatal exposure to teratogens, which are just chemical agents. So if you take a medication that you're not supposed to when you're pregnant, that is what a teratogen is. Lead and pesticide exposure, adverse events and environments, genetic variability, delayed brain maturation, problems in executive functioning. So treatments for ADHD: stimulant medications affecting dopamine, that's the most highly effective. And then non-medical interventions like exercise to get that dopamine going, meditation to kind of get yourself centered, tutoring, driving, safety training, because they have correlated People with ADHD have more reckless driving behaviors. And then, of course, psychotherapy. All right, here is a good link. I highly suggest watching this. This just talks about the differences between autism spectrum disorder and ADHD. So again, sometimes they intertwine with each other, but there are differences. Here's another great video to watch. And basically, she talks about her autism and getting a later diagnosis. So if you've ever felt like, and you're an adult and you felt like something is wrong with me, I've never known. Well, here's a woman that found out that she had autism, and for her, it's talking about how much it helped her to have the diagnosis, because then it's like, I don't feel weird knowing that, oh, this is not who I am. This is just something that I live with. So again, okay, I'm going to skip through that.
Hi, I'm Taylor.
All right. All right, so anxiety related conditions, these are things I mentioned before. We've got generalized anxiety disorder, panic disorder, specific phobia, social anxiety disorder. This is what's covered in your text. OCD, again, that's under its own category. It's not under anxiety disorder anymore, but it does bring about anxiety. All right, so for GAD, diagnosis and symptoms, persistent anxiety for at least 6 months. So that means it has to be more days than not for at least 6 months in a row. So if it's 5 months and 29 days, it's not going to be diagnosable. It has to meet that criteria. And clinicians have to be very mindful of that, because that's their license. If it's important not to overdiagnose just because someone says, oh, I have this disorder, the doctor has to diagnose. So we have to diagnose this. Inability to specify reasons for the anxiety. So with generalized, it's like, I'm just anxious, but I don't know why, right? Different than social anxiety. All right, so what are the causes? There's biological factors. So you're going to find that with a lot of these disorders, there's biology and there's psychology. It works together. It's not usually one thing, even with your disorders like schizophrenia. Schizophrenia, highly biological, but not always. All right, so when we look at this specifically, the genetic predisposition, and then there is a GABA deficiency. That is a neurotransmitter. And then respiratory abnormalities, psychological, sociocultural. We're looking at harsh self standards, critical parents, negative thoughts, traumas, and stressors. When we look at panic disorder, that is a recurrent sudden onset of intense apprehension or terror, often without warning and with no specific cause. So if you're diagnosed with panic disorder or have panic attacks, when we look at that, it's different than anxiety attacks, right? They kind of are similar, but with panic, it's like you are good, you're good, you're laughing, and out of nowhere it feels like you're having a heart attack, right? Like an elephant is on your chest, you're breathing heavily, you think you're dying. That's a panic disorder. It's out of nowhere. So it's not like there's this buildup of something. With panic disorder, your first panic attack is linked to something, but any panic attack after that is not. So there is a clear distinction. So causes, biological factors, genetic, norepinephrine, GABA, and serotonin, lactate levels in the brain, hormone regulation, responses to stress, psychological factors, conditioning to CO2. And then your sociocultural, there's gender differences in panic disorder. Specific phobia. Now, again, there are many phobias, but you have to have an irrational. It has to be irrational. There is a difference between a fear and a phobia. So it's irrational, overwhelming, persistent. Key word. It's not just fear, it's persistent fear of a particular object or situation. Spider phobia is a huge one. But again, agoraphobia gets its own classification because it's the largest phobia. All right, again, causes psychological, it's learned. A lot of that sometimes vicariously through parents, through seeing it. So again, you see it and you learn it. Sometimes we've just learned to fear, right? We've been conditioned through what we learn in school or whatever, that you fear spiders, you fear snakes. There's no real rational explanation to it. if you have the phobia. It's just that, oh, we've learned to fear through evolution. All right, biological genetic predisposition. So a parent has a phobia, they might be very sensitive, which again, when you put that on a child, they experience it even more. So you might develop this phobia due to a parent having a phobia. Fears plays an important role in adaptive behavior. It's quickly learned, treatment based on learning principles, extinction to remove the link between the stimulus and anxiety. So exposure therapy is a great one for any phobic disorders. All right, so here are some of your phobic disorders. These are just some of like your big ones. Very interesting. Some people laugh at these, especially gamophobia. That's the fear of marriage. Again, it's going to be phobic if it's irrational, if it's deviant, distressful, and dysfunctional. Major distinction. So when people say, oh, I've got this phobia, especially if they're coming to my practice, I'm like, okay, but do we really? Let me ask you some questions. And that's how I'm going to either rule out it's a phobia or I'm going to support that diagnosis. Just important. In our culture of TikTok and looking at the internet, we overemphasize these disorders when really you don't. An example, let's say you are afraid of flying. You have a fear of flying. So you'll become panicky, your heart will race, but you'll get on the plane. You might clench your fist, you might like close your eyes and do something. That is a fear. If it's phobia, let's say you got a job offer paying $1 million a year. If you have a phobia, a true phobia, you're not going to fly to that new job. Or if it's on the 70th floor of a building and you're afraid of heights, you're not going to take that job because your phobia is going to outweigh that money you're making. So that's just kind of a good distinction to think about. All right, social anxiety, huge disorder among young people, intense fear of being humiliated or embarrassed in social situations. Again, it's irrational. It's not actual reality. Most of the things that we fear, like 90, I think it's like 90%, I forgot the exact number, are based on irrational, that it will not ever happen. But again, your brain is very powerful. So causes, again, biological, genetic predisposition. We see it from our parents. Neural circuitry, the way your brain is wired. Serotonin, oxytocin. Psychological factors, parenting styles. That, if you have an authoritarian parent, like do as I say, helicopter parenting, that can lead to social anxiety. If a parent is like, don't go outside, don't do this, don't, whatever, it can lead to those things. So those are the psychological. And then attentional bias toward negative information. All right, OCD. OCD. So obsessions are the thoughts, they're recurrent. Again, it's got to be consistent. The compulsions are the behaviors. So in order to be diagnosed with OCD, you can't just think about it. There has to be the ritualistic repetitive behavior of doing. Now, a lot of what people think OCD, it's like, oh, checking locks and doors and step on a crack and all that stuff. Yes, those are, but it's more than just those things. Again, we have to look at this. It's persistent anxiety provoking thoughts and or urges to perform repetitive ritualistic behaviors to prevent or produce some future situation. Again, we see what the causes are here, and they're going to be a little bit different. Overactive brain regions like in the frontal cortex or basal ganglia. Neurotransmitters, you're going to have a lower level of serotonin, dopamine, and glutamate. And then it could be digestive functioning issues. And then, of course, psychological factors. We've got life stress, difficulty filtering out negative thoughts. All right, so here are the diagnosis and symptoms, again, for OCD. Here's something that falls under the OCD category, hoarding disorder. Here is a great SciShow explanation of hoarding disorder. Here's excoriation, that's skin picking. I don't have a video. There are videos for it. I just didn't include one. Trichotillomania, hair pulling. You can find these under like the show My Strange Addictions as well. Or if you just look this up, you can find your own videos on that. Body dysmorphic disorder, that's a huge one. So here is a really good video on BDD. PTSD, again, this one is overstated by people. I don't like hearing it. I don't like hearing people say, oh, I have such PTSD, because until you actually are diagnosed with PTSD, it is no joke and it is horrific to live with. So I would very much encourage not overusing that word unless you're actually diagnosed with PTSD. So again, extra credit. What should we not just willy-nilly say? Oh, I have such PTSD. No, unless you're diagnosed with that, or unless you absolutely know it is a disrespect for people with this disorder just to casually say, I have PTSD. Develops through exposure to traumatic event, a severely oppressive situation, cruel abuse, or a natural or unnatural disaster. You don't have to witness it firsthand to be diagnosed with PTSD. However, again, this has to be very intense. Symptoms may be immediate or emerge after months or years. So, a lot of times with PTSD, it's not, you don't find that, like, your trauma doesn't happen immediately. It does, but sometimes it doesn't. It could take several months or years for that to happen. We find that it usually is more immediate, but it's not always. So it may take a while. So criteria for this: flashbacks. That's a big one with PTSD. PTSD, avoidance of emotional experiences, emotional numbness, impulsive behavior, excessive arousal, having a startle response. So if you hear like a loud noise, you're like, someone in a different position might just be like, oh, but someone with PTSD might actually freak out. And some couples, some married couples, they have to sleep in certain rooms because some people, and you can look this up, but there have been cases, usually males, not always, but males have actually killed their spouses while sleeping, having a traumatic dream, and then choking their wife or shooting them. So, again, I don't joke about PTSD. So, yeah, next time you think about like just saying it to say it, think about that. And again, extra credit for letting me know. All right, so and then also difficulties with memory and concentration. So there's lots of bouts of memory forgetting because of dissociating. So again, these are criteria of PTSD. Now, a lot of people that say, "Oh, I have such PTSD," they don't have any of these criteria. None of these criteria, or maybe one of them. So again, very emphatic about that. All right, causes. History of trauma. Again, you have to have a history of trauma, cultural background, genetic predispositions. All right, here are some PTSD example videos. So, what are the signs? This is called the Doctor's Channel. 6 signs of complex PTSD. So, or CPTSD. Dr. Ramani with MedCircle. She is a phenomenal doctor. And then, how are they different? So, CPTSD versus PTSD. Dr. Tracy Marks discusses what those differences are. So again, I highly suggest those videos. All right, DID. This is dissociation, dealing with extreme stress. Very different than PTSD. Problems integrating emotional memories. Types: dissociative amnesia, extreme memory loss regarding personal identity caused by extensive psychological stress. And then DID, again, it has to be 2 or more distinct personalities or identities. So before anybody tries to self-diagnose DID, please watch these videos. So this is Oprah interviewing, I think it's Kim Nobles. She interviews Kim Nobles and Trudy Chase. Very sad case right here. So this is Kim Nobles. This is a woman with 2,000 personalities. And then this is Trudy Chase. Very sad case, but these are legitimate. So highly suggest watching those. All right, click here if you want to click this video. This is a great example from long ago of DID. So diagnosis and symptoms: one individual possesses 2 or more distinct personalities. Each personality has unique memories. Their memories are different than each other, so that they don't share the memory. They don't share they can kind of overlap, whatever, but they have their own unique memories, behaviors, and relationships. One personality is dominant at a time. So if someone has 16 personalities, only one is dominant at a time. That's important. Causes extraordinarily, key word, extraordinarily severe abuse in early childhood. If it did not happen in early childhood, usually before the age of 5 and under, they have stepped up a little bit, then you cannot be diagnosed with DID. So this is the real Eve. Well, there's Eve White, Eve Black, and then Jane. Jane was the one that was integrated. So if you want to kind of work through in therapy, there is a technique, it's called integration. So you integrate all of the personalities. This is a live, legitimate, through the doctors working with her. Of course, this is her pseudo name. That is, this was Sybil. That was her pseudo name right here. That's what she actually looks like. This is Three Faces of Eve movie trailer based on the real life person of this one. And then what's interesting, this is Sybil from 1979 movie trailer, that's Sally Field. So the woman that played the one that had the disorder in this movie later in life played the doctor that treated Sybil. So these are movie trailers. Excellent. Watch them. They're phenomenal. All right, Runs in Family, and then of course Social Contagion. This is, again, you can watch this video, Sybil, a Brilliant Hysteric. It's a discussion about her, and again, great video to watch. All right, must skip.
Go to the website
Through it. All right, here's your depressive disorders. Mood disorders in which the individual suffers from depression and unrelenting lack of pleasure in life. Again, these disorders have to be deviant, distressful, and dysfunctional. All right, major depressive disorder, diagnosis and symptoms. Major depressive episode that lasts for at least 2 weeks. So it has to last 2 weeks at a time. Daily functioning is impaired. Sometimes you will not get out of bed. You won't shower. You won't eat. You won't do anything, brush your teeth. Symptoms may include depressed mood most of the day, reduced interest in activities, trouble sleeping or sleeping too much, fatigue, loss of energy, sense of worthlessness, hopelessness, guilt, problems in thinking, concentrating, or making decisions, recurrent thoughts of death and suicide, no history of manic episodes. That's MDD. And again, it's more than just sadness. This is clinical. Here's your etiology. So the causes, again, there are many different causes. I'll let you read through that. Here is a very interesting gender difference in depression across cultures. You can pause and look at this. All right, bipolar disorder characterized by extreme mood swings. Again, key words, extreme. That include mania, overexcited, unrealistic, optimistic state. Pattern of episodes usually separated by 6 months to a year. Causes, strong genetic component. So it's going to be strongly genetic. So usually if parent has bipolar and they have multiple kids, usually it's going to get passed down to one of their children. Swings in metabolic activity in cerebral cortex, levels of neurotransmitters. All right, so here are some really good videos that I put in here about bipolar disorder, because again, this is one that sometimes people say, oh, I have bipolar, or they say someone else does and they don't. But this really lowers that stigma. I love all of these that I included. So this is what does bipolar 1 feel like. This is with Katie Morton. She is a licensed marriage and family therapist. What it's actually like to live with bipolar 2 disorder. So now we're looking at 2. Halsey, the singer, talking about her bipolar. Selena Gomez opens up about her bipolar on Nightline. Then this is a clip of My Mind and Me documentary with Selena Gomez. Also, My Mind and Me, this is the trailer for it. Kanye West talking about his bipolar disorder. Demi Lovato opens up about her bipolar. Mariah Carey reveals her battle. And then there's a TED Talk, Ups and Downs of Bipolar Disorder. So great videos that really look at the truth of bipolar. Again, that was, that was a the genetic influence. So people that are identical twins, high predisposition, looking at fraternal and then other. This shows you what under a scan, what mania and depression looks like. So you got top and bottom brain in depressed state, and then middle is brain in manic state. All right, eating disorders. So we've got anorexia, bulimia, and binge eating. So with anorexia, basically it is the starving of oneself, just eating just enough to live. You have a distorted view of what you look like. Often you look in the mirror, it's just psychological. You look in the mirror, you're thin, but you think you're fat or heavy. So anorexia is, again, distorted body image. There's a high mortality rate amongst psychological disorders. Bulimia, that's binging and purging. So it's eating and then getting rid of the food. Preoccupation with food, fear of developing overweight, being overweight. What happens is after enough time of bulimia, you swell up, so you actually gain weight. So it's important to get help, especially because acids coming up. If you're throwing up, if you're using laxatives, you can develop issues down below. And then binge eating disorder, there is no like purging. It's just recurrent episodes of excessive eating. So again, here's a link. The doctors are photo filters destroying your body image and self-esteem. So another great video. Again, causes, there's biology, and of course we're going to have psychological factors as well. All right. Schizophrenia, severe disorder characterized by highly disordered thought processes. A lot of people do get schizophrenia confused with another disorder. Psychosis, a state in which a person's perceptions and thoughts are fundamentally removed from reality. So people get this disorder confused with DID. They are very, very separate disorders. Typically diagnosed in early adulthood. There are children. I think I have a video in here that goes over Janny. She's now an adult, but as a child, she had childhood schizophrenia. I mean, still does. If you have it, you have it life. It has a high suicide risk, typically requires powerful medications to control symptoms. So it's not one that you can kind of just not get medication. This is one you need medication, or you're going to have those delusions and hallucinations. So your positive symptoms, which means it doesn't mean like it's happy, it means it adds to. So it's those hallucinations, delusions, and referential thinking, disorders of movement, catatonia, so being completely still. The negative symptoms, social withdrawal, behavior deficit, so kind of removing yourself from people, flat affect, so kind of you're kind of there. There's no smile, there's no nothing there. It's just kind of like looking through you. Cognitive symptoms, difficulty to sustain attention, memory, self-reflection, impaired ability to interpret information and make decisions. Basically, the etiology of schizophrenia is heavily biological, so genetic predisposition. Yes, there are psychological factors. You could look at the vulnerability stress hypothesis. And then, of course, you have your sociocultural factors. And you could develop schizophrenia from drugs. So there's been drug-induced schizophrenia as well. This looks at the risk in genetics. Very interesting when we look at identical twins. There's actually a case of quadruplets that all had schizophrenia. Again, here are some really great example videos. So this is Janny with schizophrenia, 60-minute interview with Charles Manson. Very interesting. He was diagnosed with schizophrenia. This is a raw interview with him. This is one of the things that if you have schizophrenia that you can experience as word salad. It's just kind of talking and not making sense. In this interview with Charles Manson, he actually has word salad. So it's a very interesting video. This is an example of a really old video of a live patient experiencing catatonia. And then this is the movie trailer for A Beautiful Mind with Russell Crowe. Great true story of what's his name? Last name is Nash, and he had schizophrenia, and I won't give anything away, but excellent movie, won several awards. I think it came out in 1997. I used to show it in all of my psychology classes, so great movie. And then BBC Real World Examples, What the Voices in My Head Say. So this is a great one for auditory, what it sounds like. Yeah, this is a big chapter. Now we're looking at personality disorders. These are your cluster B, the ones that I said are very difficult to treat. So your cluster B, you can click on this link for a good explanation. It's chronic maladaptive cognitive behavioral patterns that are thoroughly integrated into an individual's personality. So Jeffrey Dahmer, this is an example. Murder, Mystery, and Makeup with Jeffrey Dahmer. So I love Bailey Sarian. She is an awesome podcaster. And she talks about different kinds of serial killers and just killers in general. So if you watch this, you can subscribe to her channel. She is amazing. And then if you click on this link, no, there's not. It's right here, actually. This one here, though, if you click on the picture here, this will go into the Ted Bundy examples. I think I have another. All right, so with the diagnosis, they are law breaking, violence, deceit, without regret, so they have no empathy. People with antisocial personality disorder lack empathy. So if you have empathy at all, you will not be diagnosed with ASPD. They are impulsive, irritable, reckless, and irresponsible. Some of the causes, biological factors, so genetic, brain, and autonomic nervous system differences, childhood abuse, and gender differences. Especially with men, you'll find kind of like stringent fathers. That's Dr. Romney, I put a link in here, goes over the differences between a sociopath and psychopath. So very interesting. All right, let me click on all of these. Eileen Warnes is a huge one to talk about. She was diagnosed with borderline personality disorder. So click this link, it talks about that. With borderline, instability in interpersonal relationships, self-image and emotions, impulsivity, some of the features, unstable affect, unstable sense of self and identity, negative interpersonal relationships, self-harm or threat of self-harm. This is an awesome movie called Monster. So this is Charlize Theron. This is Christina Ricci. She had to gain over 50 pounds for this role, and she did an amazing job playing Eileen Warnes. Click on this video. It's an interview with Eileen Warnes. And then, of course, I wanted to include the Mean Girls depiction of histrionic personality disorder. Oh, sorry. So some of the causes again are genetics, childhood abuse, and then irrational belief. One is powerless, unacceptable, and that others are hostile. And they also, people that have borderline also are very hyper vigilant. I think I'm done with this one. All right, here is one amazing narcissistic personality disorder. This is the criteria to be diagnosed with the disorder. So you will see that presentation, you have to have at least 5 of 9 to be diagnosed with this. Again, what did I say earlier about this disorder? Most people do not go to get diagnosed. They go to manipulate. This is a link. You're not crazy. You're just dealing with a narcissist. Great video. This one, gaslighting. So Dr. Romney talks about gaslighting in this video. And then gaslighting, what does it mean? So these are, I believe I included links to movies that have gaslighting in it. Again, great videos. Highly suggest watching these. All right, so as many as 90% of people who die by suicide are estimated to have a diagnosable mental health condition. So now we're looking at suicide. There are gender differences. Women are more likely to attempt suicide, but men are more likely to actually complete suicide. We have biological factors. Genetics does play a role in suicide, and having low levels of serotonin, which is the reason it's important to see a psychiatrist to have that diagnosis if there's depression and take medication for that. Also, poor physical health, especially with chronic disease, that can, heighten the level of suicide. Psychological factors, psychological disorders and traumatic experiences, immediate and highly stressful circumstances, substance abuse is a huge one, victimization by bullies. And then if you're looking at Thomas Joiner's interpersonal theory of suicide, it does involve two factors in understanding this. There is a desire to die. Social needs are not met, feel a lack of belonging and a burden to others. You may not be a burden, but that's how you feel, and that is validated. So it's just understanding that theory. And then acquired capacity for suicide. So most people fear death and or pain, so they build a tolerance for pain. So less consistent support. So people either have that desire to die, right? Or they have that acquired capacity for suicide. So again, their fear of death or pain, they begin to build a tolerance for that. So this is just, one of many theories of the reason people commit suicide. Your sociocultural factors, chronic economic hardship, lowest rates in countries with strong cultural and religious norms against suicide. So here's just something to note. I won't read that, but you'll look at suicide attempts by US adolescents from different ethnic cultural groups, with Alaskan natives having the highest rates of suicide. All right, when someone is threatening suicide, here are some things, here are some just kind of tips of what you should do. Ask direct, straightforward questions in a calm manner. So it is okay to say, are you thinking about killing yourself? You don't want to sugarcoat it. You don't want to tiptoe around it. You don't need to. That is a myth. So you want to be direct, you want to be straightforward, but you also want to be calm. You don't want to freak out, cry, and say, oh my God, are you gonna, you don't want to do that. Just be calm, but also be direct. Be a supportive listener. That's the main thing, is being a listener. Emphasize that unbearable pain can be survived. Take the suicide threat very seriously. Don't think someone's just talking. Actually listen to that. Ask questions. Stay with the person until help arrives if they are actively talking about suicide. Encourage the person to get help and assist them in getting help. Ask them, do you want me to go with you? Do you want me to make the call with you? Do you want me to take you? Just being that person that's there for them. And then let the person know that help is available. They can call or text 988. All right, here's what we don't do. We don't want to ignore the signs. We don't want to refuse to talk about it if the person actually wants to talk about it. We don't want to react with horror or disapproval by saying, you shouldn't do that. You shouldn't feel this way. You have so much to live for. Why would you think that way? You're selfish. We don't want to do, because all that does is it ignites the person's desire to commit suicide even more. So again, we don't want to do any of those things. And we also don't want to offer false reassurances that everything will be all right or make judgments. Again, you don't want to say, oh, so-and-so has it worse than you, or, just give it a week. It's going to be okay. Sometimes they're only thinking in that moment. So again, we want to be very, what's the word? Opposite of false, obviously. So true in what we're, talking about. And we don't want to abandon the person after the crisis seems to have passed. Usually, the highest rate of suicide happens when a person appears to be in a good mental state, or the word happy, right? That's a word that's very overused. So again, third point of extra credit is, what is a word that is so overused? The word is happy. A lot of people say, I just want to be happy. Happy is an emotion, right? If you're happy all of the time, that's manic, right? Manic. If you're sad all of the time, that's depression. We want to be content, right? You want to have meaning in life. So as I digress here, again, so you have 3 points of extra credit here, right? So again, I'm reiterating these things. They're very important, the do's and don'ts. If you are thinking right now about ending your own life, please know that you are not alone. Reach out to a loved one or call or text the Suicide and Crisis Hotline at 988. Please reach out to someone. talk to someone. If someone is unable to be there for you, I advise, and I'm not an advice giver at all, reach out to someone else or call that hotline. My own clients have reached out to this hotline. They've called me, they've texted me. But if I've been unavailable, which is rare, but if I've been on vacation or had my phone off and there was ever a case, they have reached out and they have let me know, and they said it was very, very helpful. So again, if you're in that crisis, please either reach out to someone or call 988. All right, so combating the stigma, we're almost done. Mental health conditions are very common. The label of a psychological disorder can be very sticky. It can be dicey because there can be prejudice and discrimination, illusory correlation with violence, stigma as a barrier for treatment. But we are seeing that there is less of a stigma now with treating mental health conditions. Resist thinking of people with disorders as defined by the condition. Like I said earlier, people are not their disorder. Very important. They may suffer with this, they may go through this, but they are not what their diagnosis is. So we want to create a positive environment and empower those positive role models in our life. Okay, with that said, whoo, last time I did this, it was like an hour and a half, so I have lowered it. I hope you enjoyed it. I hope you got a lot out of it. And again, there are those opportunities in there. So if you have any questions or comments, please feel free to reach out to me, and I will see you in the next video lecture. All right, peace.